Do we not have, are we on? Okay. Can you hear me now? Sort of? Okay. Welcome, committee. Welcome, staff. And Conferees, thank you so much for being here. I might take a little bit of grace here for some personal privileges. I have 5 of my grandchildren in the audience there and my wife. It's President's Day. They were out of school, and so they're visiting the Capitol and having a good time around here. So thank you for that. Stand up. You guys going to stand up? Stand up. Good looking, good. Very good. Committee, thank you for that. Okay, let's get the meeting started.
Mr. Chairman, I just wonder if any of them are quail hunters.
My oldest son, Jack, is.
Okay.
All right. With that, we'll start the hearing on HB 2365, establishing the South Central Regional Mental Health Hospital. And Jenna, will you give us a little bit of an overview on this? Thank you.
The person to speak for me was way taller than I was. Okay. Good afternoon, committee. Jenna Moyer, Advisor of Statutes Office. This is House Bill 2365. And although it's a long bill, it's a fairly short explanation. This bill establishes the South Central Regional Mental Health Hospital in statute as a state hospital, as well as creating the South Central Regional Mental Health Hospital Fee Fund. And that's in Section 1, and then Sections 2 through 26 update references to state hospital, state psychiatric hospital, and similar terms throughout statutes by adding South Central Regional Mental Health Hospital to these reference terms, and also eliminates outdated references to facilities like the Rainbow Mental Health Facility. This bill would take effect on July 1st upon publication in the statute book, and I'll be happy to answer questions.
Very good. Committee, questions of Jenna? Seeing none, thank you, Jenna. Okay, next we have a proponent, Scott Bruner, Deputy Secretary. Scott, welcome to committee.
Thank you, Mr. Chairman, members of the committee. My name is Scott Bruner. I'm the Deputy Secretary for the Department for Aging and Disability Services, working with the state hospitals, and I'm here before you today as a proponent of House Bill 2365. The revisor did a great job explaining what we're trying to accomplish in the bill. It creates a new state agency designated as the South Central Regional Mental Health Hospital that would operate under the jurisdiction of the Secretary of KDADS. This new state psychiatric hospital would primarily serve the South Central counties in Kansas in cooperation with our existing state hospitals in Larned and Osawatomie. The expanded bed capacity in our state mental health system was included in recommendations from the 2018 Mental Health Task Force report. And we use that report to guide a lot of the work we've been doing at KDADS over the last several years, including asking in the fiscal 23 budget to build a new regional state mental health hospital. This bill authorizes that hospital and that we envisioned through stakeholder work, and that's been ultimately funded by the legislature to operate. I'm not going to read all of the testimony that I wrote, but I did want to highlight a couple of things. The South Central Regional Hospital will have 104 beds. Serving adults committed for involuntary mental health treatment under the Care and Treatment Act, and also criminal defendants needing competency services as an extension of the state security hospital at Larned. Like Jenna mentioned, the bill also then updates a lot of the statutory references that talk about Larned, Osawatomie, State Psychiatric Hospital, just to make sure this facility was included in those designations. The bill also designates the catchment area, or the counties that this hospital will serve, including Sedgwick, Butler, Cowley, Harvey, and Sumner counties. And I think you may have an amendment as well, a technical amendment to update the other catchment areas for the other two hospitals, and make sure we've got all the counties listed in statute. Section 5 of the bill updates the statute to clarify that the Secretary of KDADS can allow admissions outside the catchment areas or transfer of patients between state psychiatric hospitals if we're low on capacity or need additional resources at one hospital or the other. I did try to include in the testimony the timeline of the project and some of the partnerships that we've built. So I won't read all of that to you, but this is a project, a very unique project for a state building. The Sedgwick County is our primary partner, and we've funded through the county the acquisition of property, the contracts with design firms, the general contractor agreement as well. And ultimately, the county is building this hospital for us, get it to the point of substantial completion, and then they'll turn it over to us to operate as a state hospital. The site that we've acquired is at the corner of MacArthur and Meridian in South Wichita. Clearing the site started about 2 weeks ago, and we expect the construction to be done by October 2026. The county will transfer ownership of the building and all the equipment to us by the end of 2026, and we're expecting our first patient to be admitted in January of 2027. The bill does one other thing that I don't want to neglect to mention. It does rename Parsons State Hospital and Training Center to just be the Parsons State Hospital. This is something that we've been talking quite a bit about with the Parsons staff and others. The term training center in that title refers to a time when the primary goal of our state institutions for people with intellectual and developmental disabilities was to teach basic skills and not really think about longer term treatment. Parsons State Hospital provides a wide array of psychological services that encompass the needs of the entire person and address not only behavioral issues but their past trauma. So we think just renaming the hospital, taking the training center off, is a more accurate representation of the range of services that are provided on the campus. So that's in this bill as well. ks and our partners in Sedgwick County have been working on the design and construction of this hospital for a little over 2 years. Like I said, it's a joint project. The funding has all been appropriated. There's $15 million that was appropriated in fiscal years 2023, 24, 25, and it's in the 26 budget as well. There's also $26.5 million that the legislature added in 2024 that moved us from building a 50-bed hospital to the 104-bed design that we have. And there's also $25 million in spark funding that's part of the project as well. So all the money's in the budget except for 26, and that's in the plan to get the construction completed and start the operations. We'll be back next year with a full budget for the hospital. That'll be part of the 27 budget. I talked about it's 104 beds. It's going to have, like our hospitals at Larned, Osawatomie, beds for adults that are in mental health crisis and also criminal defendants that need competency established. Did want to mention a little bit about the support that we gained for the project over time and the capacity that we're going to be adding to the system. This project has the support of a large number of stakeholders across South Central Kansas. The governor formed about 18 months ago a 15-member advisory panel that's made up of legislators, Sedgwick County officials, law enforcement from the county, mental health providers, and several other people that represent the community to really help advise us as we were going through the design process for what this hospital ought to be and how it would fit into the existing services that are already available in Sedgwick County and in the region. Like I said, we've been meeting for 18 months. We've met almost every month over those 18 months. And the panel's done several recommendations in their final report that helped guide us on the definition of the services that we're going to provide for acute mental health treatment and forensic. One of the recommendations was to have an explicit agreement with law enforcement, emergency medical services, and fire in the county and city of Wichita, just so all those relationships are well defined. It was a really good recommendation and something that we're working on now. Had several public meetings as part of that process as well to keep the public informed. I just think all that work that we've done over the last 18 months has been really important for people to know what we're building, what we're trying to achieve, and then help us be as successful as we launch the hospital in a couple of years. Authorizing the South Central Regional Mental Health Hospital. We've tried shortening it to something else, and we haven't quite gotten there yet, but authorizing the hospital in statute this session will give us time to establish the operational and accounting structure well before the construction's complete. We're moving forward on the administrative parts of the hospital already. We've appointed an acting superintendent that's leading the project and recruiting the leadership team. and working on the programming and the procedures and operational parts of the hospital well in advance of anything being built. But we're trying to be planful. Hired a facilities director, and then the teams at Larned and Osawatomie are contributing a lot of their time to help us with staffing, with programmatic clinical programs, policies and procedures, things like that. So we'll really be ready to hit the ground running when the building is available, when construction is complete. Thanks for the opportunity to provide proponent testimony. We're really excited about the project, appreciate all the support we've received from the governor and the legislature over the last couple of years, and I think this is a really important next step to have the operational structure in place before we open. So with that, Mr. Chairman, I'm happy to stand for questions or take them at the appropriate time.
Very good. Thank you, Scott. Committee questions? Representative Turner.
Thank you, Mr. Chair. I was reading and it says there's no fiscal note, but I assume that's because you're saying that it's already been fully appropriated, so it's already in the budget, and there's no incremental fiscal impact? Is
There
that correct?
will be in the budget cycle for next year. So when we requested the original appropriation of $15 million, that was to get us started on construction and operations for a 50-bed hospital. In the deliberations, I'm happy to go more through that if you'd like, but where we are now is building a 104-bed hospital, so we'll need a little more money to staff and operate a larger building. But part of this year is building that budget and thinking through all of those dynamics, and it'll be part of the request for fiscal year 2027, which you'll review next session.
Because you had said that they appropriated $15 million in 23, 24, 25. Did I get that right?
Yes, that's correct.
Okay.
And 26 is proposed.
Okay. All right. Thank you.
Representative Droege.
I guess I need a little more clarification on this building fund also. Thank you, Mr. Chairman, and thank you for your testimony. But it says here that you have the 15 million, then 26.5 million, then 25 million in Spark Fund. So we're talking 66 million plus to build a facility.
The construction budget alone is about 86 million. And so we've had appropriated through 26, if that's included, is about 111 million. So part of that's going to go to operations. That's not part of the construction budget. But the building itself is 86 and a little over 86.5 million.
Committee, further questions? Seeing none? Very good.
Okay,
Thank you, Scott. Next, we have Amy Campbell, Kansas Mental Health Coalition, no stranger to this committee.
Thank you, Mr. Chairman. My name is Amy Campbell. I represent the Kansas Mental Health Coalition. The coalition is a roundtable organization. We have members that include all of the community mental health centers. There are psychiatric hospitals, there are private hospitals, the psychologists, the psychiatrists. We have a wide variety of members that meet to develop our consensus agenda. We have been testifying about the state mental health hospital crisis for decades. The building of this South Central Hospital is a culmination of years of input from communities, from mental health stakeholders, from facilities, and more. We very much support this bill and urge you to get it passed and moving forward. It feels like there's never going to be any walls. Mr. Chairman, we've been working on this for so long. I have information in my testimony that talks about the history of state hospital beds in Kansas, how we got to where we are today. The fact that the 2019 Mental Health Task Force report included a bed study that talked about how many beds we should have in the state of Kansas versus what we do, and recommended that the state of Kansas add more than 200 state hospital beds to our capacity. In fact, since that report, we have decreased the number of state hospital beds that we have in Kansas due to a number of issues, not the least of which had to do with the pandemic and the workforce crisis that we have today. One of the very most important aspects of opening this hospital in Wichita is the need for workforce development, growing our own, graduating more mental health professionals in that area who can staff this facility, because we have programs in Wichita that are very concerned about having to compete for staff. We are thrilled that the Kansas legislature has supported this multifaceted approach to adding capacity in the state of Kansas. If you look at the last page of my testimony, it talks about the many different aspects of the mental health continuum of care that help to support inpatient capacity for the Kansans who are suffering a mental health crisis today, and what it takes to build those services also at the community level, including community crisis beds, crisis intervention centers, and the certified community behavioral health centers at the local level. I am around the Capitol a lot, and I am always happy to sit and visit with any of you about this history and why this is so important. But suffice to say, we're thrilled to see this project moving forward, and that Kansas is going to be doing a better job of addressing those in our state who are very vulnerable and who suffer these crises on a regular basis. And the fact that we have invested funds in diverting them from the inpatient services so that they can be served at the community level and live in recovery. Thank you very much, Mr. Chairman.
Committee questions of Amy. Representative Berquist.
Thank you, Mr. Chair. Thank you, Amy. How many beds are available and usable right now, as in staffed, across the state?
Fewer than 200.
Fewer than 200. And this will add 104, but we're looking for more staffing.
So this will add 104, but 50 of those are for competency evaluation and restoration. 50 of them would go to add on to that less than 200 number for psychiatric beds that are available to people in crisis in the community who need inpatient hospitalization.
Thank you, ma'am.
Committee, further questions? Very good.
Thank you.
Thank you. Committee, I'll bring your attention to written proponent, Sheriff Jeff Easter from the Kansas Sheriff's Association. With that, we'll close the hearing on 2365 and open the hearing on 2316. Jenna will give us an overview.
Thank you again, Mr. Chair. Committee, House Bill 2316 directs the deposit of civil penalties collected for violations of correction orders issued by either the State Fire Marshal or the Secretary for Aging and Disability Services into two new created reinvestment funds. So Section 1 amends KSA 39949. It establishes the Adult Care Homes Civil Monetary Penalty Reinvestment Fund, and it would direct monies collected into such fund to be used for grants awarded to licensees under the Adult Care Home Licensure Act for projects approved by the Department for Aging and Disability Services. So what would happen is when a adult care home or a disability community service provider is inspected and then a violation or a correction order is issued by either the secretary or the state fire marshal upon reinspection, that the secretary or the fire marshal could issue a civil penalty. Under current law, that civil penalty would go into the state general fund, and this bill would direct those funds from the state general fund to these two newly created funds to be reinvested for grants for current licensees. Section 2 amends KSA 39-2016 and establishes the Disability Community Services Providers Civil Monetary Penalty Reinvestment Fund, and it directs monies collected into such fund to be used for grants awarded to licensees under KSA 39-2001, which is Disability Community Service Providers for projects approved by the department. And this bill would take effect on July 1st after publication in the statute book. I will be happy to answer questions.
Committee questions? Representative Orpezzo.
Thank you, Mr. Chair. Jenna, with these funds, are there any specific grants, or is it strictly for like people who are already diagnosed with disabilities? Is that what the grants are? Is there a specific list for grants they'll be offering?
Yeah, thank you, Mr. Chair. Representative, so the grants would be awarded to current licensees under these statutes. So when let's say the adult care home, they get this civil penalty for violation of a rule and reg or a state fire marshal, like you don't have working smoke detectors, and then they come back to do the reinspection and your smoke detectors still don't work, you get issued that civil penalty. So this is not a lawsuit. This is just a civil penalty administered by the licensing authority. That civil penalty currently, under state law, goes to the general fund. This would put it in one of these new funds. And then the language is, it is for grants awarded to licensees, for projects approved by the department to benefit the health, safety, and welfare of program participants served by the center, facility, hospital, or provider. And then there's similar language for the adult care home, projects approved by the department to benefit the health, safety, and welfare of residents served by the adult care home. So it's not specific grants, but just whatever's approved by the department to benefit the residents of facilities.
Committee, further questions? Representative McDonald.
Thank you, Mr. Chair. Just to make sure I'm clear, these could be for-profit entities that break the rules maybe repeatedly, and they get the opportunity to be rewarded with being given a grant to fix the problem after they've repeatedly put people in danger potentially? Is that what we're saying?
So there is not language about what licensee would be allowed to recoup that money. I don't think that the intent was that it would go back to the violating party. I think that it would go into a kind of a lump fund, and then licensees could then apply for that fund to upgrade facilities or whatever projects are. And it would have to be approved by the secretary.
Could I have a follow-up question? But it would be possible for, say, a for-profit entity to repeatedly break these rules, putting people in danger or neglecting them in some regard, and applying later for the grant and getting it paid for through this fund. Am I right?
Thank you, Mr. Chair. And that would be assuming that they are allowed to maintain their licensure. Obviously, if you break too many of the rules, you don't get to keep your licensure. But I guess in theory, that would be possible, yes.
Any further questions? Very good, Jenna. Thank you. Okay, we have as proponent Lacey Hunter. Lacey, welcome to committee.
Thank you, Mr. Chair. Members of the committee, I'm Lacey Hunter, Survey Certification and Credentialing Commissioner for the Kansas Department of Aging and Disability Services. Jenna did a really good job explaining this bill. I'm happy to answer or further answer any of those questions. But I do want to point out a few different things in my testimony beyond what the bill is proposed to do. So first and foremost, the bill is not going to increase the number of citations written by our department. To the licensed providers, the bill is really just to redirect the funds that are currently being paid by these providers when they receive a monetary penalty. And then that fund that those penalties would go into is, as Jenna kind of explained, it would be more of like a pot that anyone who's licensed under that statute could then apply for a grant. Those grants we would use to allow facilities to increase their training, implement new technology, fix major physical plant and equipment issues, and really just kind of ensure that the providers who are paying into those funds or have infractions and or those who are licensed under the fund and need issues or have issues and need assistance with those can access those funds that they're being paid into. Currently, there are no funds set aside for this. So there's no grant funds for providers that are licensed under the adult care home statutes or under the IDD or behavioral health statutes under 2002 or under Article 9 of Chapter 39. So these funds would kind of create that and allow for those grant funds to be available to those providers. The second thing that this bill that we're asking for it to do would be allowing for us as an agency to use those funds in an emergency situation. So I have a pretty specific example that I'm going to use the rest of my testimony to talk about. So a couple days before Christmas this past year, me and my assistant commissioner received a call that Monday morning that there were 2 Home Plus facilities. The owner called us and said, I'm financially insolvent. I don't have staff. The staff that I do have are leaving by 5 o'clock today. I got 16 people I need to relocate. I, as the commissioner and as our agency, we don't have an emergency fund for me to dip into. So luckily, we were able to work with the facility. The long-term care ombudsman's office was heavily engaged, MCOs that were there. There were only a few residents that were at Medicaid. Most of them were private pay. But luckily, most of the staff worked at another Home Plus in the home within the community, and we were able to find locations for everyone that day. But if we would have had access to a fund like this, I could have brought in a third-party management company, and I could have allowed operations of that facility to continue for at least 30 days and provide those residents and their family a 30-day notice, which is required under regulation, instead of the less than 24-hour one that they received that day and that they received 2 days before the holiday. Thank you, and I'll stand for questions.
Very good. Committee questions. Representative Weichel.
Thank you, Mr. Chairman. How much money are we talking about? Because in the fiscal note, it says that the civil penalties assessed is pretty rare, but you're talking about a fund that would be sufficient to sustain a nursing home for 30 days, which I assume is pretty costly. So how much money are we talking about?
Sure. So I will tell you that some of the other testimony you'll hear will propose adding some other funds to it to sustain the fund, because that is the concern that some of the other people have. That I would agree with that, and I think that those other things that you're going to hear from Kylie Childs, I would agree with them, which include the licensure fees. But I did run some numbers for you guys because I wondered if that would get asked today. So I did from 2021 through 2024, the total number of civil monetary penalties assessed for adult care homes. And so in 2021, there were 6 monetary penalties assessed. The average amount for those penalties was $6,333. And then it kind of increases over the years. So in 2022, there were 15. The average amount was $6,300. In 2023, there were 44. The average amount was $7,096.14. And in 2024, there were 47, and the average amount was $4,935.96. That's a lot of numbers. I can provide that to you in writing if you'd like it as well.
So just clarification for your question, I have one too. How much is the total of that? Because I can't add that fast.
Okay, I didn't. I can do the yearly totals, and I should have done one overall. I can give you yearly totals, but I don't have those 4 numbers calculated. But so like the 2024 yearly total is $231,999. So
maybe after the break here for a minute, you can find somebody with a calculator and tell us how much that is. That would be great.
No problem. Yes.
Committee, further questions? Representative Valparaiso.
Thank you, Mr. Chair. Thank you for your presentation. And in the facility that called you a couple of days before Christmas, were they for-profit or nonprofit?
I believe they were just registered as an LLC. I don't know that they had if they had proclaimed a profit or not for profit, but I don't believe they had a what is it, 1001(3)(c). I don't believe they had that status, but I could go back and double check.
So okay, so probably just an LLC.
Mm-hmm.
Okay,
correct.
Thank you.
Representative Blex.
Thank you, Mr. Chair, and thank you for your presentation. We seem to have a problem finding staff, and you talked about having a management company come in. The cost is going to dramatically increase with that. If they done it 30 days, and I support that concept, but, I mean, it looks like we're having problems finding staff, but yet you think you can get one and pick phone calls? Am I hearing you right?
Well, so in my experience, I've been in with the commission since 2017, which had me in with the commission during the Skyline ordeal, which it caused a lot of receiverships, and there was a big temporary management. But in that time, I was the enforcement manager for adult care homes, so I was the person that did a lot of those transactions. And ever since then, I am now the person that many management companies have come to me and said, how do I get to be that management company? Can we have a conversation? I want to talk about my company coming to the table and being that management company. We think we could provide those services. So I've had a lot of in-state and out-of-state managers who currently operate in Kansas come to me and say they would like to be on the list of being able to provide those services should we need them as an agency.
Thank you. Thank you, Mr. Chair.
Representative McDonald.
Thank you, Mr. Chair. I'm understanding that we have a shortage of inspectors to begin with. Is that correct? How much of a shortage do we have? Is there a plan to remedy that? Because I would think if we had more inspectors, we could find more violations, and this fund would be funded more appropriately and in a
Certainly.
timely fashion.
So if you look at my numbers from 2021 to 2024, we actually have increased the number of survey staff that we've had in that category for the adult care home segment. By 4 people. 2 of those 4 have been filled. We currently have 2 vacant positions, but that leaves, currently we have 6 staff or 6 survey staff that oversee the adult care homes. And then if you were to switch over to the other side of the bill for the licensed providers under 2002, we're looking at somewhere around 13 staff that are out there surveying.
Committee, further questions? Representative Bryce.
Thank you, Mr. Chair. Thank you, Lacey, for the presentation. Just a quick question about the civil penalties and the grant. So the civil penalties are specific violations where the penalties are collected. Will the grants correlate to the problems uncovered through the civil penalties, or are the grants more broad in nature, or will they specifically address those things that were found deficient? Thank you.
As we've worked through this and talked to this with our stakeholders, we have fully said that if in this grant were to be created, we would want to go to the table and create policy and procedure on how and who would be applying, what would be applicable to apply for, and making sure that all those stakeholder groups were involved and understood and were agreeing with the process for vetting who does and who doesn't receive a grant. And then we would administer the policy and procedures that we as a collective group agreed upon.
Okay. Thank you, Mr. Chair.
Committee, further questions? Representative Droege.
Thank you, Mr. Chairman. Thank you for that presentation. I have I guess, a little curiosity. We have somebody who makes a decision that you have a problem, then makes the fine, then collects the fine, and then uses the fine the way they see fit. And then you say it won't increase the citations. This is almost too good to be true, but I'm a little curious about that and how it all fits together and why the fire marshal has got this all going. I don't know if that's a clear question, but thank you.
Sure, I can try. So to clarify, the fire marshal doesn't currently issue any fines that pay into the civil monetary penalties as they exist in Article 20 and Article 9. It is solely the Department of Aging and Disability Services that's assessing and providing those fines to those individuals. Anytime a fine is assessed, the individual and that provider is provided an appeal right to exercise should they choose to. And that comes with the assessment of the fine. Even prior to the fine, what the stem of the fine would be that there was a finding that was against their license, the minimum requirements for licensure. There was an incident, it was cited, that's where the fine comes from. When their incidents are cited, they're also given an opportunity to dispute that citing. So under Article 9, those adult care homes are allowed to do what's called an IDR, or an independent review, informal independent review. And then under Article 20, those providers are allowed to request mediation for any of the citations that are cited. So there's a couple of steps within there that if they don't disagree, or if they disagree with what we as surveyors have found in their facility, for them to exercise their right to disagree.
Did that answer your question? Very good. Committee, further questions? I just have one. So differentiate between the two types of facilities. Sure. State-owned, federally.
Yeah.
Thank you. So
it's specifically in adult care homes, so when you're looking at the people under 923, we're talking, under that umbrella is adult daycare, boarding care home, assisted living, residential health care facility, home plus, nursing facility, and nursing facility for mental health. When you're looking at the people who we license under 39, Article 20, we're looking at the IDD providers for day and residential services. We're talking about psychiatric residential treatment facilities for the psych under 21, private psychiatric hospitals, substance use disorder facilities. I think that's everybody. I might be missing one. There's a list in there. I'm sorry. I try to keep it all memorized, but
I was looking for something a little simpler, federal versus state.
sure. Okay, of all those things I just said, the only people that are federal in that category would be the nursing facilities and the nursing facilities for mental health.
Thank you for that. Committee, further questions? Okay, seeing none, thank you very much. Next, we have Kylie Childs. Welcome to committee.
Good afternoon, Chairman Carpenter and members of the committee. My name is Kylie Childs. I'm the Director of Government Affairs with Leading Age Kansas, which is the state trade association for nonprofit and other mission-driven aging services providers. So thank you for the opportunity to provide proponent testimony on HB 2316. So currently, our CMS certified nursing homes and nursing homes for mental health already have a civil monetary fund that is managed by CMS. So anytime a fine is issued for those CMS certified nursing homes and nursing homes for mental health, that goes into a CMP fund for them to then submit for grant applications that do everything from enhancing resident quality of life and care improvement, staff training and development, technology and equipment, COVID-19 and infection control, as well as specialized programs. So right now, the issue is there is no fund for our state licensed only facilities, which would be all those other adult care homes, excluding those CMS certified nursing homes and nursing homes for mental health. So what we would like to do is support this fund. And since it is on a smaller scale with the amount of CMPs or fines that are issued to it, we do have concerns about sustainability. So we did have 2 recommendations in our testimony. The first being that we would like to specify this fund is exclusively for adult care homes, excluding CMS certified nursing facilities and nursing facilities for mental health. That way we do not have those entities double dipping into the 2 funds, and we can keep those separate as much as possible. The second would be to redirect the adult care home licensing fees to this reinvestment fund to ensure the sustainability of this fund. KDADS did confirm that these fees currently support surveyor salaries and administration, but they are rarely tapped into. So redirecting them would have minimal fiscal impact, but it would be enough to help with sustaining this fund and allowing some grants to move forward for our state licensed only facilities. So I did include where that language would change in KSA 39930 on the backside of our testimony. And in general, we are supportive of this fund and are happy to stand for questions at the appropriate time.
Any questions of Kylie? Representative Bryce.
Thank you, Mr. Chair. Thank you, Kylie. Just how much money approximately would be the adult care home licensing fees that would be redirected? Thank you.
If it's okay, I'll step aside because Lacey has figured that out for us.
Hello. So it is a very hard and moving target to do this number. So I want to explain that first of all. So today, if I made every single adult care home renew their license and pay a fee today. There are 709 adult care homes. So the way the fee is figured is it's a $100 flat fee per adult care home and then $30 per bed. And that's how you get your total for what you pay for your annual license. 709 facilities, 33,806 beds comes to a total of $1,085,380. And then I have that other total if you'd like it as well.
Yeah, I'm not sure that's the total we were looking for. The total was the total of the fines.
Oh, I thought you wanted licensure fees.
Okay.
Okay, the number I just gave you was licensure fees. The total number for fines I also have so that is 667,720.
Okay, committee questions. Kylie, could you back up? What were you talking about to do with the licensure fee?
Yeah, so right now, any of the licensure fees go into a licensure fee fund under the adult care home statute, and that is KSA 39930, and we would like to change that to come into this reinvestment fund to help with the sustainability of it.
Thank you. Committee questions. Representative Weichel.
Thank you, Mr. Chairman. And this may be a question for KDADS, but if we change the licensing fees to go into this new grant fund, that's $1 million that is going somewhere else right now. So what's it paying for right now?
So my understanding, and Lacey can help with clarifying this, when I spoke to her about this, this helps with general administrative or surveyor costs if there are any to accrue. But this is not the main fund they tap into to address those costs. It's kind of a backup fund, but I'll let Lacey clarify too if there's anything else.
I think the other thing to clarify is that the amount that goes into this fund is such a hard and moving target that it's hard to rely on those funds as guaranteed funds for our salaried staff.
Very good. Thank you. Committee, further questions of Kylie? Representative Gardner.
Thank you, Mr. Chair. Could you clarify this for me just a bit? It seems as though if we did this with the licensing fee and the fees from fines, we'd have about $1.6 million in this fund to push back towards people who have had violations to help correct those. Now, who will be picking the winners and losers in that grant fund? Because I assume the need here would be far in excess of $1.5 million. And so who would pick who gets the grants and who does not? And how do we know then that we're not creating a system where if a care facility had a deficiency and they knew they were going to get a fine for that, that they just let it go because they knew then they could pay the fine and then get remediation from this fund to correct it? That would bring more money to their facility than what they paid in the fine.
Thank you, Mr. Chair. And Representative Gardner, how it currently works on the nursing home side is the KDADS gets to look at the CMP requests that come in for grant proposals. And they review those and then decide what they're able to move forward based on the requirements that CMS has set for what those funds can be put towards. So they're looking at every application that's coming in and then deciding who is able to move forward with that grant request. And I think Lacey would be able to speak to this a little bit more, but there are some guardrails that can be put in place in terms of policy and procedure and ensuring that we're not putting funds directly back to somebody that is constantly receiving citations. That is a review history that can be looked at and taken into consideration as we're doing this. An example of a grant that we've done with our members or on behalf of our members was a program called Violet. And so back during COVID, there were these Violet air purifiers that we were able to help with putting into our provider homes to help with infection control. And so it's not necessarily going to one provider that has been issued a CMP. It's not necessarily going back directly to them. It's going to the wider breadth of adult care homes as a whole.
Thank you very much. And thank you,
Very
Mr.
good.
Chair.
Committee, further questions? Seeing none, thank you.
Thank you.
Thank you very much. Committee, I'll bring your attention to another proponent testimony, Jennifer Sork, General Counsel, Midwest Health. With that, we will close the hearing on House Bill 2316, and we will open the hearing on House Bill 2368. And who's up for that? Jenna? You do the short straw again, huh?
Right. Thank you, Mr. Chair. House Bill 2368 provides for licensure of anesthesiologist assistants. And this is your sort of boilerplate licensure act. So I'll be going through it at a fairly rapid clip. Sections 1 creates the Anesthesiologist Assistant Licensure Act. Section 2 defines terms used in the bill. One of note would be an anesthesiologist assistant. It's a person who is licensed in accordance with the provisions of this act and who provides patient services under the direction and supervision of a supervising or delegated anesthesiologist. Section 3 creates different designations of licensure and the qualifications for those licensure, including active license, requirements to obtain and renew an active license, and how a license may expire, as well as inactive license and license by endorsement, and the requirements for those licenses as well. Section 4 requires that no person be licensed as an anesthesiologist assistant unless that person has submitted their proof of education and training to the board, and the board here would be the Board of Healing Arts, passed an exam, and provided to the board any information the board deems necessary to evaluate their qualifications. Section 5 provides the circumstances under which a licensee's license may be revoked, suspended, or denied a license, or placed under probationary or monitoring conditions. These would include circumstances like acts of unprofessional conduct or professional incompetency, conviction of a felony or a Class A misdemeanor, and the inability to practice with reasonable skill and safety by reason of physical or mental illness or the use of alcohol or drugs. Section 6 would make it a Class B non-person misdemeanor for any person who's not licensed to engage in practice as an anesthesiologist assistant. Section 7 requires the board to provide for temporary licensure of anesthesiologists meeting certain criteria, and that temporary license would last 1 year. Section 8, this is on page 8, states what an anesthesiologist assistant could do while assisting the supervising or designated anesthesiologist, and requires that an anesthesiologist be physically present or immediately available in the same facility as the anesthesiologist assistant in order for the assistant to practice. Subsection B requires that the anesthesiologist who's supervising accept and be responsible for the oversight of the healthcare services rendered by the anesthesiologist assistant. Section 9 is on page 9, and it provides how an anesthesiologist may designate a new anesthesiologist to supervise an assistant. Section 10 requires the board to limit the number of anesthesiologist assistants a supervising an anesthesiologist can supervise at one time to 4 assistants. Section 11 establishes the Anesthesiologist Assistant Council to advise the board in carrying out the provisions of this Licensure Act. Section 12 requires that all proceedings to revoke, suspend, limit, or deny a license or censure a license would be conducted in accordance with KSA 652838 and KSA 652838A, which provide for discipline and non-disciplinary action against a licensee of the Board of Healing Arts. Section 13 amends, so this is your first mandatory rather than new section, and it would amend KSA 224714, and that's the statute that was passed into law, I believe, last year. And so before this time, every licensure act would have its own provisions for how to do a background check or a criminal history record check. And turns out from the FBI, some of our background checks were getting rejected because our licensure language wasn't always done correctly. And so this new statute, 224714, would put all of those background check statutes into one place and sort of standardize the language to make sure that these checks go through. And so this section would amend that statute, permitting governmental agencies to require fingerprints for employment and licensure to add applicants and licensees under this act, and allow their collection of fingerprints and require the KBI to release criminal history record information related to adult convictions and non-convictions to the board. And this would add them to the list of background checks for other similar Board of Healing Arts licensees. Section 14 amends KSA 651163 to include the practice of anesthesia by anesthesiologist assistant students enrolled in an approved course of study in the administration of anesthesia. Section 5 amends KSA 6528.127 to require that supervising licensees who delegate acts that constitute the practice of healing arts are to notify the board when terminating the direction and supervision terminated the direction and supervision request of a written agreement or practice protocol, and then this bill would take effect on July 1st after publication in the statute book. And I'll be happy to answer questions.
Wow, that was plenty.
Yes. It's a long bill.
Questions? Well, you must have did a great job, so no questions. Thank you. Okay, first proponent we have is no stranger to this committee, Rochelle Colombo. Welcome to committee.
Good afternoon, Mr. Chairman, members of the committee. I am Rochelle Colombo. I'm the Executive Director of the Kansas Medical Society and appreciate the opportunity to testify in support of House Bill 2368, which allows for the licensure of anesthesiologist assistants. The revisor did a great job of explaining this bill. It is a licensure act. So the Kansas Medical Society, which represents physicians of all specialties across the state, supports integrated team-based care, which has physician direction and supervision. We know that in your experience as patients and as loved ones go before a healthcare team, they're best served when they have a physician and a vast array of healthcare providers which are trained in different models and are regulated. So under current law, a physician can delegate a medical act to a non-physician and even to an unlicensed provider. But what this bill does would allow for regulation and licensure. That's why the bill is so long. It very, very clearly stipulates their education, their training, their requirements, and where they would be regulated, which is under the Board of Healing Arts. Another important point in this licensure bill and why we support it is it's under the direct and in-person supervision of a physician. So this is specifically an anesthesiologist. So there has been a lot of talk about workforce. There's been talk about areas in medical care where there are gaps, and one of those is in anesthesia. It is difficult to, particularly in urban areas, find enough providers to meet with the demands of surgical care, and this would allow for a licensed provider type, which can then be regulated and held to account, and we think that's really important for patients and for patient safety. They are under the direct supervision in person of an anesthesiologist, so they can't be supervised by a family physician or by a surgeon. They can't be supervised remotely. It is right there on site, but it adds another care provider to the team. For those reasons, we've supported this bill since its introduction. I believe it was first brought before the legislature in 2015, and then for a variety of reasons hasn't advanced. And again, physicians can already delegate to surgical technicians and to other medical assistants and providers, but then they're not regulated, they don't have oversight, and there isn't the same protections for patients when those providers are unlicensed. So we believe that this would grow the care team. It provides a very clear lane for anesthesiologist assistance, which is spelled out in statute and has appropriate oversight. I'd be happy to stand for any questions and would respectfully ask for your support of House Bill 2368.
Committee questions of Rochelle. Representative Steens.
Thank you, Mr. Chair. Thank you, Rachel. When you say that the physicians already have delegatory regulations over them, so because I'm still dissecting a lot of this. And so they are anesthesiologist assistants actually in some of the operating rooms here in Kansas? Because I know they don't have a license. We know that part. So, but are they actually in with these medical assistants and stuff in those rooms doing some duties, I guess?
That's a good question. And Mr. Chair and Representative, the answer would be this has been looked at. I think that, let me give you a little bit of background. So originally there was this effort to have licensure. That didn't succeed. It didn't make it through the legislative process. It was referred to the Kansas Department of Health and Environment, which statute usually requires for a new provider type to come into a licensure arrangement so that they can do a study to see, is this necessary and would it be appropriately regulated under the proposal? Back in 2019, the Kansas Department of Health and Environment reviewed this for a year. They did a study and they said, we do believe that this proposal has merit and that it's necessary. However, it can be done under delegatory authority. To answer your question, I think there's been hesitance on the part of physicians and on the part of AAs to practice without clear statutory authority. And so there have been some instances, I think, in maybe private practice where they have utilized that. But in most hospital settings, they're looking for licensed providers and for clarity where there has been some murkiness among the legislature. I imagine that the anesthesiologist assistants who are here today can answer that with a little bit more specificity, but I would tell you largely no. They are not coming into Kansas. You've got a lot of people on the border who are licensed in Missouri who can work on one side of the system but not on the other, maybe live in Kansas but aren't practicing here because there's hesitance to do that without a clear licensure authority and regulation.
Thank you.
Committee, further questions? Representative Bueller.
Thank you, Mr. Chair. And thank you, Rochelle. So this is one of those issues that I think everybody in this committee has probably been bombarded by emails on both sides. I do have a question, and I think you mentioned a little bit about this as an opportunity to grow or expand the workforce, or, I mean, or that translates to me into improved access of care. So I guess I'm looking for, whether it's from the KMS perspective, is there a possibility of cannibalizing, like in the CRNA world? Or if you look at that continuum of care, if you look at both those professions, I'm just curious. We want to expand the availability of health care wherever we can, and I don't want to do anything that would cannibalize some other field per se. So I don't know if you had an opinion on that, or if there's some piece of wisdom you could give this committee for, okay, we're trying to wrestle those two things.
Yeah.
If that makes sense.
Mr. Chair and Representative, I think that's a good question and helps to kind of give our perspective on it. So as I said, we support the full healthcare team, and they all have different roles. CRNAs and AAs would practice very, very differently, both under current law and under proposals that are, still floating in the legislature today. So CRNAs can work quasi-independently. They don't have to work under direct physician supervision. They're able to have a collaborative practice agreement with physician or dentist supervision. The Senate passed a bill today that would allow them prescriptive authority. So we think that's appropriate. That CRNAs have wonderful practice. We didn't support prescriptive authority, but understand that position of the legislature. This is different. This is adding a new type of provider to the care team. And again, they're under direct supervision. So they really function under different authority and under different privileges. And to answer your question about access, I would say, I don't know that I could answer that it expands access. I would say it expands capacity. So it's going to look different. So if you don't have an anesthesiologist in rural Kansas, then an AA can't practice there because they can't practice under another type of physician. They can only practice under anesthesiologists. So in many rural communities, CRNAs are the sole provider of anesthesia care because they're working with other physicians, maybe the surgeon or maybe the family practice physician in their area. That wouldn't be true for AAs. So it does look different on a map and where they might locate, and I think that is more about capacity than access.
Representative Turner.
Thank you, Mr. Chair. When you talk about they have to work under the direct supervision of an anesthesiologist, what is that ratio? Like how many per anesthesiologist?
And I don't have the bill in front of me. I don't believe it's limited. I know that the anesthesiologist assistants could probably answer that, but it would be, again, they have to be on site, immediately available, which generally means in the same room.
Several people flashed 4, so I'm going to guess
There
that's
you
the
go.
right
I think they're
answer.
probably
Thanks
right.
for the phone a friend. All right, thank you.
Representative Ruiz.
Thank you, Rochelle, for all your information. Sorry, this little thing fell off. Do you happen to know, or is there a map of Kansas that tells us where all the anesthesiologists are across? I'm very concerned about our rural communities and not having enough access. And living out of Johnson County, there is access, capacity even. And I know this would expand capacity for sure, but I'm more concerned about access in the rural communities where you've already said that there are very few anesthesiologists.
That's correct, and there's a variety of reasons for that. I don't have a map with me today. I could certainly look at it, but like I said, and I think this is generally understood, because of the way that statute is constructed, it's a separate practice act for CRNAs than it is for APRNs, than it would be for anesthesiologist assistants. CRNAs are able to practice anywhere in the state with physician or dentist supervision, and so it wouldn't really, I don't know that this would actually impact anesthesiology care in rural areas, because unless there's an anesthesiologist already there, then an AA couldn't practice.
Representative Blex.
Thank you, Rochelle, for being here, and thank you, Mr. Chair. That was my question. The lack of, it appears it's all going to be in the heavy urban areas and nothing in the rural as far as the AA, what you're trying to do. I know you pretty well explained that, I think. Thank you.
Representative Weichel.
Thank you, Mr. Chairman. Rochelle, so I want to make sure I understand this correctly. So CRNAs can practice quasi-independently, which I assume means they're under general supervision. So they can be in one location and the anesthesiologist can be in a different location and they're communicating by phone. So my question, I guess, is two-part. Is like, how many CRNAs is an anesthesiologist able to supervise under general supervision? Because then if we add that plus the 4 CAAs, I mean, how many total people are we possibly putting under one anesthesiologist?
That's a good question, Mr. Chair and Representative Weichel. So there are not limitations on the supervision of APRNs or CRNAs for a physician. There are limitations on the number of physician assistants, and this would limit supervision of AAs. And part of that is because of what you described, which is remote supervision or direct supervision versus on-site and immediately available supervision. And again, these are different training models, different licensure models, and different practice models. So it's a little bit apples to oranges. But again, APRNs and CRNAs, physicians do not have a limit on the number that they can supervise remotely or directly, but they do with physician assistants and they would with anesthesiologist assistants. So they really function differently in the way that they're regulated, although AAs and surgical techs and other medical assistants aren't regulated right now because they are not licensed.
Representative Berquist.
Thank you, Mr. Chair, and thank you, Rochelle. So the model in other states for AAs with doctors, is it about four per doctor, or does that fluctuate?
You would have to ask Mr. Chair and Representative Berquist, I would ask the bill sponsors, just for a point of clarity. Okay. The Kansas Medical Society did not draft this bill.
Sure.
We support it, so I would defer to them.
You were just an easy target.
I'll take it.
All right. All right. Be glad to talk to somebody else. Thank you so much.
Yeah, thank you.
Jenna, let me know when you find that out. There was a question. Could you restate your question?
Okay. The question is for a general model for the supervision of an anesthesiologist to an AA in other applications, or the kind of thing we're looking for in the state of Kansas, is it for a 4-to-1 ratio for the AA to the anesthesiologist?
Okay. And I'm sorry, Jenna, I think it's more of a research deal, and they're on that. And I just had a quick question as far as that goes. While you're doing some research, how many other states have licensed AAs? Very good. Committee, further questions? Representative Blex.
Thank you, Mr. Chair, for a second time, and I'm a little hoarse, but I'm getting over it tough. I think right over there started it, but anyhow, it looks like to me, and I support this, but it looks like to me it's a better fit for the glove in hand for the urban areas, and probably a better bang for our buck would be CNRAs, just like getting them prescriptive authority for our rural areas would probably solve a lot of our east-west rural urban deals.
If I might respond to that, Mr. Chair, I would say that is a question for the legislature. You all obviously get to determine, the extent to whom a provider may practice and whether or not they are licensed. And so they're a little bit different. They're in the same space. They function differently. And really the question before you today is, do you want to add a member to the care team that is licensed and accountable, or do we want that to just continue to fall under the physician and provide less recourse for a patient?
Very good. Committee, further questions? Thank you very much.
Thank you.
Next, we have Spencer Jones. Is Spencer here? Come on up.
Thank you, Mr. Chairman, committee. Appreciate your attention to this important issue for the state and the region. My name is Spencer Jones. I'm a native Kansan. I am a practicing CAA in Kansas City, and I represent the Kansas Academy of Anesthesiologist Assistants. We view HB 2368 as sensible, pragmatic legislation that's supported by anesthesiologists, healthcare administrators, and those in favor of open labor markets. I'd like to, with my testimony, give a little attention to some of the arguments that detractors make regarding this bill. Opponents of introducing CAAs in the state say there's no shortage of anesthesia providers. However, pull up a list of anesthesia job openings or speak to most any anesthesiologists, and you will see a much different story. About 8 pages of job openings here. The shortage of full-time CRNAs that the state is facing stems from a wave of kind of post-pandemic retirements and some relocations. Some of these relocations were actually CRNAs who moved to a kind of a different model, working for themselves, the 1099 independent contractors, what's referred to as the locum tenens employment. So this shift can potentially only further exacerbate the shortage we're seeing, as contract CRNAs are they're largely able to dictate their hours. They don't work a lot of call shifts, weekends, overnight shifts, things like that. So for a lot of these large groups in the state, when they're trying to fill these gaps in coverage, they get a little more desperate. These contract workers are able to charge more for services, and we kind of see a snowballing effect to where they can't meet the coverage. If cost is one of our discussion points today, we should definitely acknowledge the fact that widespread usage of contract CRNAs for groups without other great options increases anesthesia costs, and some of this cost can become the patient's burden. There is no difference in cost between CAAs and CRNAs where the anesthesia care team is used. So this is your urban areas. As Ms. Colombo was saying, AAs will not practice in the rural part of the state. CRNAs practicing independently will certainly be more attainable for these rural areas, but any mention of CRNAs being more cost-effective in the rural areas is an apples to oranges cost comparison, since AAs only work under the anesthesia care team model. That's why you'll see us. So we'll just be in the large tertiary care centers, urban sites, and potentially surgery centers that have anesthesiologists and are able to utilize us. It's many times up to 4-to-1, but it can be 2-to-1, 3-to-1, 4-to-1. That will vary, to answer your question. Opponents of this bill state allowing CAAs into the state will hurt the Kansas CRNA programs, one of the arguments they bring up. There are some 800 CRNAs in Kansas already, and in between the two CRNA programs, KU and Newman, there are 150 to 180 CRNA students at any one point. This 4-to-1 to 5-to-1 practicing CRNA to student ratio is more than adequate to appropriately train their students. There are plenty of CAA and CRNA programs that safely train all their students with much lower practicing anesthetist to student ratios. And then unfortunately, sometimes what we see is 1099 independent contract CRNAs refuse to train CRNA students altogether. Anesthesiologist assistants practice in Missouri. We've been there for 20 years. Oklahoma, Colorado, 15 other states. The dismay over one group of anesthetists trying to join another well-established group of anesthetists in the state we think is unfortunate. Collectively, we think we can provide for better balance moving forward by allowing for CAA licensure and passing HB 2368. There's more than enough demand for all of us. I appreciate all my CRNA colleagues very much. We work alongside them. My organization is here to constructively work with all stakeholders on this issue. Patient care should come first. I can take questions.
Very good, thank you for that. Representative McDonald, and I just might want to bring, I thought we had plenty of time, but you know how things go south in this committee, so if we could all kind of move things along, conferees also, that would be perfect. So Representative McDonald.
Thank you, Mr. Chair. I just wanted clarification. I'm not sure I heard you correctly. Did you say that there's no added cost when the CAAs are working compared to CRNAs? Because wouldn't we have to pay the anesthesiologist as well? Wouldn't it be more expensive for CAA/anesthesiologist than a CRNA?
In the anesthesia care team model, so where they oversee us, you're able to have your physicians spread out over 4 different sites by utilizing either CRNAs or CAAs. So where we work with CRNAs, our salaries are identical and the billing modifiers are identical. So it's the same reimbursement, same cost. As we mentioned in independent practice areas, places where CRNAs are not under the medical direction of an anesthesiologist, then yes, that's going to be a different cost model.
Okay, thank you.
Yeah.
Any further questions? Seeing none, very good. Thank you very much for being here, Spencer. Okay, next we have Dr. Matthew Pinniger. Doctor, welcome to committee.
Thank you, Mr. Chairman, rest of the committee for allowing me to spend a few minutes and talk to you a little bit about my experience working with CAAs. I'm a practicing anesthesiologist for the past 16 years. I currently work with the St. Luke's Health System in the Kansas City area, and I've been a resident of the Overland Park area for the last 7 years. Since completing my residency at Georgetown in anesthesia in 2009, the entirety of my career has been spent at high acuity tertiary care centers, supervising both CRNAs and AAs in the anesthesia care team model as endorsed by the ASA, the American Society of Anesthesiologists. And in addition to supervising both AAs and CRNAs, I've been involved in the training of AA students, CRNA students, medical students, teaching them, as well as training resident anesthesiologist physicians. And for about half of my career, I've also been involved in training AA students as the medical director of 2 different AA training programs. Currently, I'm the medical director for the UMKC, University of Missouri Kansas City training program, which is affiliated with the St. Luke's Health System. I'm proud of the accomplishments of the students that I've been able to help train and graduate. I'm proud of the skills that they demonstrate, as well as the skills that the CRNA students that have graduated, as well as the resident physicians that have graduated. I think that we produce a great product educationally. I'd like to state unequivocally that the clinical training that we provide AA students and CRNA students is identical. We give them the same clinical opportunities, they're doing the same cases, they're learning the same skills, they're learning the same aptitudes, and they're given the same responsibilities. And there's no difference between the skill set or fund of knowledge in the graduates of these programs that I've been able to discern. I'm currently assigned to practice on the Missouri side of the system at the main campus, St. Luke's in Kansas City, where our staffing is about half AAs and half CRNAs. And in my experience, it's been a very collegial and very respectful relationship there. They are completely 100% interchangeable in their role there. For example, a CRNA might come in, an available CRNA might come in and give an AA a lunch break at some point during the day. Or an AA who is reporting for overnight call might come in and relieve a CRNA who's involved in an ongoing case. And these kind of interactions and exchanges happen multiple times every day. And once again, to be clear, there is no skill, no clinical ability, or clinical privilege that is afforded a CRNA that is not also afforded an AA at our facility. They both work alongside each other in every aspect of anesthesia care in our hospital, whether it be in open heart cases, major vascular, neurosurgical, in the GI lab, or even up in labor and delivery. I think that they celebrate each other's accomplishments and abilities. In January, they celebrated together CRNA Week, and this week is AA Week, and they have plans to celebrate that together as well. A few years ago, I needed anesthesia myself, and the great thing about my position where I work is that I become very familiar with the surgeons and the proceduralists and the anesthesia providers in my hospital, and I know those who have particularly excellent skills, the cream of the crop, so to speak. And so I had my short list of folks that I wanted to help take care of me. And the folks that I ended up selecting were an anesthesiologist who I helped train when he was a resident, and one of my most trusted AA colleagues. And ultimately, I hope to convince you to support this bill and do what's right for the constituents of Kansas, our friends and neighbors. I trust them to take care of myself and my family members, and I urge you to allow them to take care of you and yours. Do you have any questions?
Very good, thank you. Committee questions? Representative Blex.
Thank you for your presentation. Thank you, Mr. Chair. How do you manage such great cooperation between the Board of Healing Arts and the Kansas Board of Nursing?
How do I manage that?
Yeah, I mean, you got two different boards governing CRNAs versus the CAAs. Am I correct?
Yes, they are both licensed by different entities.
That's my point.
I don't think that's a problem for us. Essentially, as long as they meet the criteria for practicing in Missouri, we hire them, and I think that people that aren't willing to get along kind of weed themselves out. So I don't think that's been a problem for us at all.
Thank you. In Missouri, correct?
Correct.
Very good. Seeing no more. Representative Steens.
Just a quick one. Thank you, Mr. Chair. Yes, hey, Dr. Pinniger, thank you for being here. I hope I pronounced that name correctly.
Yeah, that's correct, yes.
When you're in the hospitals over in Missouri, you said you work for St. Luke's. So in your hospital, just understanding the Missouri model there, and I'm not sure how it is in other states, I'm assuming it's similar, but so if you have to be there for the CRNA and the anesthesiologist assistant, is that like when they're going under and waking up, correct? And like how many can you supervise at one time?
Yes, and so I think there's a couple of words that have been used interchangeably. There's two different models for billing. There is medical direction, and it doesn't matter whether it's AAs or CRNAs. Medical direction is how the St. Luke's hospital, Kansas City, operates, and many of its other facilities, and that is limited to 4-to-1. So a physician will be involved in the preoperative, intraoperative, and postoperative management of the patient. Additionally, will be at critical moments, including induction and emergence. And so that is the medical direction model that our hospital has chosen to follow. And that is the model which AAs are committed to be a part of as well. There's another model that I'm less familiar with. It's medical supervision, where the ratios are much greater, and I'm not as able I'm not able to describe exactly how those work as well. I've never worked with one of those models.
But that's the model that you use for CRNAs and AAs on your side? in
On our
St.
side,
Louis?
yes, yes. It's medical direction, limited 4-to-1, whether it's AAs or CRNAs, and you can mix and match.
Thank you.
Very good. Thank you very much for being here. Next, we have Senator Chuck. I'm not even going to try to do that. Okay, very good. I'm glad I didn't try it. Welcome to committee, Senator.
Thank you, Mr. Chairman. It's great to be here. You've got a beautiful capital. Ours in Georgia is very nice, but we don't have all the metal you do. But I'm in the Georgia State Senate. I've been there for 13 years, and I chair the Finance Committee for the last 9 years there. But I'm here to testify on behalf of the anesthesiology assistants, of which I'm one. And, you know, maybe to make this a little bit simpler, you've got advanced practice nurses and you've got physician assistants, and they practice here. You've got advanced practice nurses in anesthesia, and you've got physician assistants in anesthesia, and we're the one group that doesn't practice here. We've been in Georgia since 1969, as was stated, in Missouri for 20 years. And actually, you might say, what's an anesthesia guy doing chairing the Finance Committee? The first half of my life was in corporate manufacturing and finance in New York, Texas, California, back in Texas. Then for my midlife crisis at 40, instead of having an affair, I went to the Emory School of Medicine. It was very expensive, but I hear it's cheaper from some of my friends that went through the other way. So I think I made a good choice there. But we're in close to half the states. We've got a long history of providing anesthesia care. At the hospital I work at, there's 13 CAAs, we call ourselves, versus 11 CRNAs. We do the same job. We get the exact same pay. We operate under the same model. Your question earlier was a good one about, isn't it going to cost more? Here's what I would say. By that anesthesiologist being there, he is pre-oping the patient. He might be putting in IVs, an arterial line, a central line, a block. He sees them after the case, so I can do surgery, and then I can do surgery, and I can do surgery. Instead of taking an hour before and maybe a half hour afterwards trying to check on that patient, he's able to do all that. So I think it makes a lot more surgeries be able to be done, but at the same time, he's got my back if I need him in the room. And so I think that's the answer to that. You know, and I know sometimes in the effort to limit competition, you may hear stuff from both groups saying one's better, one's worse, whatever. And we've never asked for independent practice. We like the model of 4-to-1. We think it's very efficient. But I did put in the literature that I gave you, that National Institute of Health study that was an 8-year study with 443,000 patients. They looked at CRNAs versus the AA model. We came in maybe this much better at 1.6%. They were 1.7%. Statistically insignificant. Both groups provide quality care. We work great together. And I think what you would see is that there's just no difference between the groups. And I know some groups on both sides may have a push study trying to say otherwise, but that's not true. There is a healthcare shortage. With the way this state's set up, what you might see is these 12 urban areas, you might see more AAs in there and some people that like the independent practice model going out to rural areas. But I'm actually been trying to retire, but there's such a shortage that I'm still helping out with the hospitals because there's a shortage all over the place. We need more providers everywhere. You've got 15 CAAs, anesthesia assistants, over in one hospital in Missouri that KU Medical bought over there that are operating under the Kansas system and do a great job. I know people try to make, you know, the fear of the unknown, and you hear stories, but everywhere it's been, we work very well together. We do a great job, and I think we all provide great anesthesia care. Any of the technical questions I could answer on that, I'd be glad to do, but I also should have said I spent some time, I'm giving my age, but back in the 80s, I was at Kansas State University, but Lawrence was a little bit more fun town back then. So I like that a lot better. But anyway, thanks for your time and your service to the state of Kansas, and be glad to answer any questions.
Very good, thank you. Committee question. Representative Berquist.
Very brief. Your midlife decision to go the direction you did, I think you probably sweetened Georgia a little bit better for my 12 grandkids that live there. Thank you.
Oh, we're glad to be taking care of them there. Thank you.
Committee, further questions? Thank you very much for
Thank you.
being here, Senator. Again, we're getting close on time, so we need to wrap it up. Kathy Perryman, Doctor, welcome to committee. Thank you very much for being here.
Thank you, Mr. Chairman, and thank you to the committee for letting me testify. The microphone's fighting me. As you said, my name's Kathy Perryman. I'm a resident of Leawood, and I am here to support licensure of certified anesthesiologist assistants. I represent myself, the Kansas Association of Anesthesiologist Assistants, the Kansas Society of Anesthesiologists, and Kansas Medical Society. My history is a little different than most of my colleagues because I went to nursing school when I got out of high school. And I worked for several years as an ICU nurse, and then I went to nurse anesthetist school at KU and became a nurse anesthetist. And I practiced for several years doing that. I realized that there was a gap in my knowledge base and skill set between myself and my supervising anesthesiologists, and I wanted to do what they did, and I wanted to know what they knew. So I went back to medical school and for 4 years, and then I did an anesthesiology residency and fellowship, and then came back to Kansas City and practiced for over 3 decades in Kansas City. While I was practicing in Kansas City, I was also, well, mostly in Missouri. I practiced on both sides of the state line, but my hospital had the most beds in Kansas City, Missouri. And the Missouri passed the licensure for certified anesthesiologist assistants, and they joined the care team in my hospital over 15 years ago. So I've worked with nurse anesthetists for, I worked with them for over 30 years, and I worked with anesthesiologist assistants also for over 15 years. And as has been stated here, they have a different track to get into their specialized training. It's a pre-med track rather than a nursing track, but when they take they go through their education, they end up being, they look interchangeable in the jobs. You can't tell the difference in the operating rooms. People wouldn't know the difference if they didn't have on their badge what their certification was. So I can attest from personal experience with them that the CAAs have the knowledge base, the manual skills, the clinical judgment, and the vigilance required to perform their jobs in the same capacity as nurse anesthetists. CAAs are firm believers in the anesthesia care team, physician-led model, and they only practice with anesthesiologist supervision. So in my experience, we all worked very well together. It was an interchangeable team, and I highly recommend it. Now, the Kansas Society of Anesthesiologists has filed multiple licensure bills you've heard about over the past many years, and followed all the instructions given by both Senate and House committees. So to recap that, after introducing licensure legislation, we were requested to take the issue to the KDHE Technical Review Committee. The Kansas Association of Nurse Anesthetists requested that. And that was finished in 2019 with recommendation for licensure. And since then, it's really been very difficult because we've had such opposition from the Kansas Association of Nurse Anesthetists. We were asked to talk with them about reaching a compromise, and the first time they wouldn't meet with us, and then they finally did meet to negotiate a compromise, but it was not forthcoming. So the licensure bill's been reintroduced, and delegatory authority was also approved, but it's been a problematic pathway because of a residual statement in regulations, is what I understand. So I highly recommend licensure. I think that's the best pathway to go, and it's been recommended by the KDHE and the Board of Healing Arts. And we should follow through with that.
Very good. Thank you for that. Committee, some brief questions? Seeing none, thank you, Doctor, for being here. Okay, committee, I'll bring your attention to written proponent only. There's quite a list of them there. Next, we have opponents. Jeremy Salisbury. Jeremy, welcome to committee.
Thank you, Mr. Chairman and honorable members of the committee. I'm Jeremy Salisbury. I'm the current president of the Kansas Association of Nurse Anesthetists. We respectfully request that you do not support House Bill 2368, and there's several reasons for that. Anesthesiologist assistants do not improve access to care in Kansas. Yes, they may bring some more numbers into our rural communities, but that brings about some other problems that will be testified on here shortly. CRNAs are trained to practice independently, while anesthesiologist assistants are trained to be dependent. And you can't really say you're going to increase the access to care when you have to have another provider supervising an assistant. So that takes away a trained anesthesia provider away from the OR that could be working. AAs are, like I said, they're not trained to be independent. CRNAs are, and we are not interchangeable, despite what proponents may say. CRNAs can function outside of an anesthesiologist. In the state of Kansas, the statutes state that we can provide anesthesia upon the order of a physician or a dentist. Now, when that physician or dentist is giving us that order to provide those services, they're not telling us what to do. They don't even really know what we're doing, quite honestly, unless they had some extensive time in anesthesia training during their medical school or residency. But they're basically just telling us, hey, I want you to provide anesthesia for my patient so that I can do what I do over here, either surgery, heart surgery, knee surgery, dental procedures. But AAs have to have that anesthesiologist there. And earlier it was stated by KMS that the anesthesiologist assistants will be accompanied by the physician anesthesiologist in the OR suites. Well, if they're going to be supervising them in the OR suites, then if they're allowed to supervise up to 4 different people, then how are they going to be supervising them in the room at that time? And there are certain guidelines that are they're required to be in there for. So upon induction of anesthesia and emergence, they need to be immediately available. That's not a requirement for nurse anesthetists. We're trained to be there and do that on our own. Another question that was brought up previously also is how many CRNAs can a physician anesthesiologist supervise? They can supervise as many as they want, but the way they're billing is differently. When they're billing as medical direction, it can only be 1 to 4, but if they're billing as supervised, that means they're just billing for my services, and then they're there available if we need their assistance with something. And we have great respect for our physician colleagues. They bring a lot to the table. We work in a lot of different practice settings with them. Sometimes, as said previously, we work with them in anesthesia care teams. But the places that are really maximizing the use of their anesthesia providers are using a more supervision model where everybody can work to their full scope of education and training. It was asked earlier how we can cannibalize. I believe Representative Bueller used that word. The only cannibalization that's going to happen if you bring AAs into the state is the cannibalization of our anesthesia training programs. Currently, we have 2 programs in the state that we're going to talk about here in upcoming testimony. But what happens with those programs whenever you bring AAs in, AAs cannot train nurse anesthetist residents. They're not allowed to. And so if you have an urban facility where all these high acuity patients are getting taken care of, that's going to be limiting our ability to train in those sites because medical residents are getting trained, AAs are getting trained, and then now CRNAs also are being trained. And there's just not enough cases to go around. And it's already a problem in Missouri. Missouri State University has an anesthesia program, and when those students are going to Kansas City, the feedback I'm getting is they're limited on their acuity of their patients that they get to take care of there. So their training is not as good as it could be. It was asked earlier if AAs can work with delegation in the state of Kansas. If AAs are currently working in the state of Kansas under delegation, they are going against KDHE regulations, which state that you must be a licensed provider to be providing anesthesia services. I know we're short on time, but if Kansas demands more anesthesia providers, then we need to be investing in our programs that we have right now. We have fine residency programs for our physicians, and we have 2 great nurse anesthesia programs. And we should be investing in those because the majority of our state is made up by rural areas, and the majority of those areas are taken care of by CRNAs. And if you're taking away our ability to train in the urban areas where these AAs are supposed to be, you're going to take away our ability to provide services in the rural communities. So that concludes my testimony. Again, I urge you to oppose HB 2368, and I'll stand for questions. Thank you for your time.
Committee, maybe a brief question. Representative Bex.
Thank you. CRNAs do not have a DEA number, do they? Not?
Not currently, sir.
What about AAs, CAAs? Do you know? They don't have one either, do they?
I know they don't have one in Kansas.
Okay, thank you.
Representative Steens.
Thank you, Mr. Chair. I see that you're retired from the Army, I think it said. And so can AAs practice in the military?
Not currently.
Okay, thank you.
And there's multiple reasons for that. Because if you get put on a forward surgical team as an anesthesia provider, you need to be a fully capable, independent provider. And I know that they're very capable, as previous testimony has stated, but not to function independently.
Thank you.
You're welcome. Thank you.
Very good, committee. Seeing none, thank you very much for being here, Jeremy.
Thank you for your time.
Next, we have Donna. Is it night? Is it that simple?
I need a bell.
Wow, very good.
Yeah.
Okay, very good. Welcome to committee.
Thank you. Thank you, Chairperson Carpenter and members of the committee. I really appreciate speaking today in opposition to Bill 2368. I've done this many times over the years because of my expertise in nurse anesthesia education. I do want to emphasize that I retired in June, so I no longer work for the University of Kansas, as I have in the past. But certainly my role as an educator, as the department chair and director of clinical education, I worked extensively with all of our rural partners to train students, and I want to speak to that in just a little bit. I also want to emphasize that I am a lifelong Kansan. I grew up in a town of 250 people, so I grew up in a very rural area in Franklin County. Got 3 degrees from the University of Kansas, my bachelor's, master's, and doctorate degree, and then after practicing as an RN and a CRNA in the Kansas City area, I went back to KU to teach and then ended up being the administrator of the program for a number of years before I retired. I can tell you that the testimony given earlier today was very general about the ease of finding clinical cases and clinical sites for the SRNAs, the student registered nurse anesthetists. That is a big job because we have a lot of students. The KU program increased their numbers from 24 to 36 it's been a little less than 10 years ago now to help meet the needs in our area and in our state in particular. So a 50% increase in students meant we needed a lot more clinical sites. In the Kansas City area, KU Hospital is our primary clinical site, and we can have over 30 SRNAs scheduled a day at that hospital. There's also anesthesiology residents at KU Hospital every day. If KU Hospital or any of these other urban hospitals started hiring AAs, then every room that they're in, every case that they do would not be available to an SRNA. AAs are not qualified to supervise SRNAs in clinical, and our accrediting body does not allow it. I was also a national on-site accreditor, so I visited 1 or 2 other nurse anesthesia programs every year to re-accredit them, and I'm very, very familiar with all of the accrediting policies. So if you have any questions about that, please don't hesitate to ask. I think, as you can imagine, having 36 students in a doctorate program, and all of these nurse anesthesia programs across the United States are now clinical doctorate. That was a requirement as of 2022. So a 3-year clinical doctorate program, and this is after you are a registered nurse, so a bachelor's degree, about 4 years, sometimes takes people 5 or so to get their degree, then work a minimum of 2 years with a minimum of 1 year in critical care nursing, so that you have that nursing experience and you know how to take care of patients in an ICU before you go to the nurse anesthesia programs. So that's what it's built on. We struggle with certain types of case numbers, getting them, cardiac in particular. I think you can appreciate that we have great clinical sites all throughout the state, but El Dorado, Parsons, Salina, some of even the more small cities like that don't do cardiac, so we can't get any cardiac cases there. And we have 108 students to find clinical cases for. I don't know how we can possibly make up for that if we bring in another provider that they cannot work with. So again, I want to emphasize SRNAs can only be trained in clinical by CRNAs and anesthesiologists. It will really affect our rural care of patients, and this is something that I am very passionate about. We need to take care of our Kansas public, and if our students cannot get the training that is required at these urban hospitals, and that's where most of them are in Wichita and Kansas City, then I don't see how we could possibly continue to take 36 students a year, and that would mean graduating fewer nurse anesthetists in our area. I think that that would be the reality of the situation. Our colleagues in Missouri have huge problems with clinical sites, huge. Missouri State University that Jerry already talked about, they have so many AAs in the Springfield area that they have virtually no clinical sites in Springfield, and they have to go out of town for all of their clinical training. So that's a problem. That's just a real problem logistically. We use a lot of the urban hospitals, but again, when Menorah will only take 3, Centerpoint in Independence on the Missouri side takes 3 students, but they take 1 student from KU, 1 from Missouri State, and 1 from the Truman program. So we can only send 1. So it's kind of piecemeal, 1 at a time, 1 or 2 at a time. At these other sites, they get the bulk of their training at KU, especially for these specialty cases, cardiac, neurosurgery, the big vascular cases. Pediatrics can be hard to get. I'm just really worried, and that's why I am opposed to this bill. I'm really worried about the programs and worried about their clinical training. And I'd be happy to take any questions.
Very good. Thank you
Thanks.
for that. Committee, a few brief questions. Seeing none, thank you very much,
Thank
Doctor.
you.
Okay, committee, I'll bring your attention to opponent written only from Susan Hoffman, Caitlin Adair, a neutral written only from Susan Giles. Oh, no, that's virtual, so that's not, it's written only, okay. All right, very good. So with that, committee, I'm going to close the hearing on 2368. I'm going to come back to Bill 2365, work that. Committee, do I have a motion? Are there objections, committee, to working the South Central Mental Health bill? Seeing none, so we will start working that. Do I have a motion?
Mr. Chair, I move that we move House Bill 65 favorably for passage.
I have a motion, a second by Representative Reese. Committee. Representative McDonald, discussion.
Representative Weichel.
Weichel, I'm sorry.
That's okay. It's an honor.
Wrong side, okay.
I think there was mention from KDADS of technical amendments about catchment areas for counties. Is that accurate?
We're getting there.
Oh, okay.
Okay, committee discussion. No. Yeah, I needed a motion for amendment. Representative Howell.
Thank you, Chair. I'll make a motion for the amendment as KDAD suggested.
Very good, thank you. And committee, a second.
Second.
A second by Representative Ruiz. Now we're on track, folks. Carly, are you ready to explain the technical amendment?
Thank you, Mr. Chair. Committee, this would be on the back side of the amendment on page 11. It would strike Butler, and then later on in the line, insert Cloud after Clay County, and then strike Cowley, if I'm pronouncing that right. And then in line 15, it would strike Sedgwick. Then on line 22, strike Harvey. Line 24, insert Ottawa after Osborne. And line 26, strike Sumner.
Committee discussion on the amendment? Seeing none. Representative Howell, you may close.
Thank you, Chair. I close my amendment.
You've heard the motion. All in favor, say aye.
Aye.
Opposed, same sign. Amendment passes. Back on the bill. Discussion on the bill, committee. Seeing none.
I'll move my motion as on the bill favorably as amended.
I have a motion on the bill as amended. All in favor, say aye. Aye. Opposed, same sign. Bill is passed. Okay, committee, I think that wraps up our session. And I want to thank you guys for all your attention and everything with everything. And we probably do have some loose ends to tie up here after turnaround. We're in the process of getting some bills blessed that we may be working through a few meetings and stuff. So stay tuned. So with that, we're adjourned.